My name is Andrew Kelso. I'm a consultant neurologist at the Royal London Hospital working for Barts Health, and I run the epilepsy service. Today's neurology PLT was covering the areas of epilepsy and headache, and I spoke about epilepsy. The PLT was devised really in response to work that we've been doing with the CCG, looking at how neurological conditions within Tower Hamlets can be better managed and how the interface between the community and secondary care can be enhanced. We went through some case presentations surrounding epilepsy, trying to use these to illustrate common clinical problems that we encounter in secondary care, and really to get the opinion of GPs as to how they would manage things in primary care and how we can help bridge that gap. We talked about the challenges of the first seizure and how first seizures might be referred into secondary care. I introduced a new service running at the Royal London where patients from primary care with a first seizure can be referred by email to my first seizure clinic, and if the referral is received quickly enough, we will see them within 7 days if possible. Contact details for me for that service and for all other epilepsy and neurology related services will be provided at the end of this presentation. We then moved on to some issues surrounding contraception and epilepsy, titration of anti-epileptic drugs, and the management of difficult epilepsy patients. We talked a bit about the interactions between lamotrigine and the combined oral contraceptive pill, and in particular that although lamotrigine doesn't seem to affect contraception in women taking it, the contraceptive pill can make lamotrigine less effective, and this can sometimes be a cause for breakthrough seizures. We also talked about the effects of sodium valproate during pregnancy. Sodium valproate is more likely to cause major congenital malformations in women who are pregnant that are taking it than some of the other anti-epileptic drugs, and it is not the first drug of choice in epilepsy in pregnant women. However, for some women with epilepsy, sodium valproate will be the only medication or the best medication for controlling their seizures, and this has to be taken into account. And there will be some women who have epilepsy who take sodium valproate in which other anti-epileptic drugs are not appropriate. In this situation, a risk assessment will have to be performed by both primary and secondary care and the patient advised accordingly. We then went on to talk about the management of epilepsy and seizures in patients with substance abuse issues. Alcohol and recreational drug abuse are both strong risk factors for developing epilepsy, as are previous neurological infection like meningitis, head injuries, stroke, and advancing age. Patients with substance abuse issues are often chaotic and difficult to engage with treatment, and it may not be pragmatic to investigate them in the same way that we investigate other patients. Finally, there are some patients with substance abuse issues that manage their seizures with clonazepam or other benzodiazepines, which causes problems professionally and therapeutically, and this would not be the medication of choice in these patients. There's not much consensus as the best way to manage these patients, but my choice is to give them levetiracetam between 500 and 1000 milligrams twice daily as some sort of background protection against seizures and status epilepticus, with the acceptance that they may not achieve optimal seizure control so long as they are still abusing alcohol or recreational drugs. Sometimes these patients manage to control their substance abuse issues, and in this situation we could manage their epilepsy in a more traditional way, but my approach is a pragmatic way of reducing risk and containing problems where traditional approaches aren't useful. We finished off by talking a bit about the management of patients with drug refractory epilepsy, when to refer back to general neurology or epilepsy services, and the differential diagnosis of patients with refractory epilepsy. There is certainly a misdiagnosis rate of epilepsy of between 5 and 20%, depending on who the patient is assessed by. And non-epileptic attack disorder, which is also called psychogenic seizures, dissociative seizures, or functional seizures, is a commonly missed problem. It's not always clear how to manage patients with non-epileptic attack disorder, and whilst they have to see a neuropsychiatrist for specialist assessment and advice regarding treatment, that process can be lengthy and access is limited. GPs can help by letting patients talk about their symptoms and not by providing time limits on discussing those symptoms. This is often therapeutically useful, and it's called draining the symptoms. There are options for onward referral, and Dr. Ruth Taylor is a consultant liaison psychiatrist who works for East London NHS Trust and also at the Royal London Hospital, and is happy to see patients from Tower Hamlets with neuropsychiatric disorders. Finally, I emphasise that the Lishman unit, which is a specialist neuropsychiatric unit at the Maudsley Hospital, is a national referral unit, and if funding can be secured, patients can be referred there as well. Finally, we can offer a degree of support from the epilepsy service at the Royal London Hospital, and it's always reasonable to discuss these patients with us if you feel it can be helpful.
My name is Dr. Maniar. I'm a consultant neurologist at the Royal London Hospital and Basildon and Thurrock University Hospitals. So I was invited today to give a talk to the general practitioners in the Tower Hamlets area, and I thank them for inviting me. So today in the talk we covered common headache scenarios with the help of two examples, and we tried to cover different types of headache syndromes that GPs frequently encounter in their GP practice. So we talked about episodic migraine being one of the most common headache syndromes that a GP would encounter. We talked briefly about the diagnosis, but we concentrated mainly on the treatment part of it. We talked about NICE approved treatments, acute treatments, as well as preventive treatments. We covered acute treatment with triptans. NICE recommends the using sumatriptan 50 mg tablets either with paracetamol or an NSAID like naproxen, starting from 250 mg to 750 mg as the first line treatment for acute relief of migraine headache. If sumatriptan is not useful, then I think GPs should consider using other triptans. And the choice of the other triptan would depend on the patient characteristics. So if the headache episode itself is prolonged, so meaning for several hours in a day or a day or two, then one can think in terms of using a longer acting triptan, and they have two choices here: Frovatriptan 2.5 mg, which has a T-half of 26 hours, being the longest acting triptan. Other option is Naratriptan 2.5 mg, which has got a T-half of 8 hours. If the particular patient's pain is very fast developing and reaches peak intensity rather rapidly, then rizatriptan wafers can be useful and should be preferred. When the oral route has been used but not effective or cannot be used because of significant nausea or vomiting, then nasal zolmitriptan 5 mg nasal spray is a good option. When patients are using triptans for episodic migraine, they should limit the use of these for 2 days in a week, i.e. a maximum of 8 days in a month, to avoid medication overuse. We talked about the treatment of nausea and vomiting in episodic migraine, and the options would include buccal prochlorperazine, i.e. Bucostem, 3 mg or 6 mg tablets, which can be effective, but often people find the taste of it to be rather not to their liking, and in that case the options would include domperidone 10 mg tablets or a melt form. Metoclopramide was asked by one of the persons in the audience. I would prefer prochlorperazine or domperidone to metoclopramide, but metoclopramide is also an option which can be used in an oral form or a rectal form. We then went on for preventive treatment of episodic migraine, which I would like to cover in the preventive treatment section of chronic migraine. Basically, the drugs are the same for both conditions. We talked about chronic headaches, and I gave an example of a typical case scenario of a 36-year-old female who comes to you with daily headaches for the last 6 months, preceded by episodic headaches in the past, with the worsening especially around the time of menstrual periods, and the headaches being associated with nausea and phonophobia. We talked about the diagnosis, and somebody in the audience rightly mentioned that this patient has a chronic daily headache, which is a correct term, but which only suggests that the patient has had headaches for more than 15 days for the preceding at least 3 months. So within that umbrella of chronic daily headache, one has to look into what is the diagnosis of a particular patient. Now, this patient had a lot of migrainous features to their headaches, including menstrual worsening, nausea, phonophobia, as well as a history of episodic headaches in the past consistent with migraine, and therefore the diagnosis was chronic migraine. We also identified through discussion that the patient was overusing analgesics. Definition of overuse is the usage of simple painkillers like paracetamol or NSAIDs for more than 15 days in a month, and the usage of triptans or opioids for more than 10 days in a month for at least 3 months. So this patient was overusing analgesics in the form of paracetamol and brufen. So we established that. We also established that the patient did not have a history of migraine aura. That is important because the patient was taking a combined oral contraceptive pill. Now, patients with migraine aura, NICE recommends, should not be using a combined contraceptive pill and should rather be using a progesterone only pill because the risk of stroke is relatively higher in patients with migraine with aura who use the combined or estrogen containing contraceptive pill. We then talked about the possible treatment options. Once again, we visited the acute treatment options that we just discussed in terms of episodic migraine, and then we talked about NICE recommended treatment options for chronic migraine prophylaxis. So NICE recommends the usage of propranolol, and ideally I would start this at 20 milligrams once a day, increasing by 20 milligrams in a week or two, at 1 week or 2 weekly intervals, until a maintenance dose of 40 milligrams twice a day, which can be further increased up to a maximum of 200 milligrams in 2 divided doses in a day. We talked about other options recommended by NICE, and that includes topiramate as well as gabapentin, and NICE also recommends acupuncture, 10 sessions of acupuncture as an adjunct to treatment of chronic migraine. The case history mentioned that this particular patient that we discussed today was on amitriptyline 20 milligrams, but could not take this any further because of drowsiness. So during the discussion, I made it clear that patients need to be told that any prophylactic that they are put on needs to be taken for at least 3 months before a decision is made whether it's effective or not effective. Of course, unless there are significant side effects which can make it necessary for us to stop the treatment option before the end of 3 months. They also have to go on a proper dose. So I would start on a small dose and increase the dosage until the patients are better or until the maximum dose is reached for this indication. And the maximum dose that I use for propranolol for chronic migraine prophylaxis would be 200 milligrams in two divided doses. For topiramate, it would be 50 milligrams twice a day or 100 milligrams twice a day as a maximum. For gabapentin, it would be 600 milligrams 3 times a day as a maximum. So we talked about the importance of using a headache diary, and I gave them an example of a diary that I have created, so which can be used for patients. And obviously there are other headache diaries available on different websites, including the Migraine Trust and the Migraine Action website. Often some of the GPs rightly mentioned that often patients don't come back with their diaries, and I appreciate this situation. We just have to advise our patients strongly to sort of encourage the usage of diaries, because this is a very important way to keep track of their progress, both in terms of the number of headache days that they experience as well as the number of days in a month that they use painkillers for. So we also addressed the fact that our patient was overusing analgesics, and we talked about how to advise patients to not do so. Then we advised at what stage this patient should be referred, and we said that despite this advice of using the preventives at a good dose for a good duration of time, and using the acute medication options. If despite that patients are symptomatic, then certainly they should be referred for tertiary care management. We also discussed that when patients are referred for these reasons, it will be very, very useful for the specialist to know the various treatment options that have been tried in the past, along with the duration as well as the maximum dose that has been reached, so that decisions can be made whether a particular preventive option has been adequately tried or not. It is also essential to establish this because patients not responding to preventive medications can possibly be candidates for botulinum toxin type A injection treatment, Botox treatment for chronic migraine, which has also been approved by NICE. And I mentioned to the group that patients not responding to any of these options, including a greater occipital nerve block, can then be considered for intravenous DHE treatment in the hospital or occipital nerve stimulator as a treatment option. We also discussed a second case of episodic cluster headache, and I mentioned to the group and informed them about the NICE guidelines for acute treatment as well as chronic treatment. Acute treatment includes usage of sumatriptan 6 mg subcutaneous injection as a first choice, plus 100% oxygen inhalation with a rebreather mask at 12 to 15 liters per minute for at least 15 minutes. So these are the two acute treatment options. The third option, second choice option, would be zolmitriptan 5 mg nasal spray. And chronic, i.e. preventive treatment options for cluster headache would include verapamil, which is the first choice recommended by NICE, and other treatment options include lithium carbonate and other options for which the evidence is not as good as verapamil and lithium would include the usage of topiramate, epilim and melatonin, to name a few. We also mentioned that all patients with suspected cluster headache should be referred for care at tertiary level, since this is an extremely severe pain disorder, and therefore the treatment has to be optimum right at the start. I mentioned websites, and I have given leaflets to the group, which included websites for migraine as well as cluster headache, and also a very good paper by Goudsby et al. About the usage of headache medications during pregnancy. Thank you very much.